to get your CMA credits.
All right, and also we have 4 really interesting speakers here. We're actually going to do a panel discussion with Q&A at the end, so please hold your questions until all of the speakers have had a chance to present. But if you do want to put your questions in the online module, those will be here and will stay until the end for us to look at.
So the first speaker will be Dr. Joy Snyder from Washington University School of Medicine in St. Louis.
Okay, thanks and good afternoon. Glad to see everybody. I'm going to lead this session off, and even though it's a biomarker session, I'm mostly talking about clinical diagnosis to set the context for biomarkers. So these are my disclosures. And the key things that I'm supposed to talk about, so this is the bottom line. If you pay attention now, you can then tune out. But biomarkers are necessary and useful and are exploding right now, which is great. But the clinical diagnosis is the first step and also the hardest step. Amyloid immunotherapy is likely most effective if we start early at the very mildest stage of disease, but this is when the disease is hardest to diagnose. And I'm going to talk a little bit about our experience at WashU implementing amyloid immunotherapy. And finally, as we all know at this meeting, these are exciting times and things are moving ahead. So just to review, I'm going to talk about the stages of Alzheimer's dementia. And at WashU, we use something called the clinical dementia rating, which a few of you may have heard of. But it starts at CDR0 when people are normal. Hopefully, we're all CDR0s most of the time. Then progresses to the point where there's a very insidious onset of very mild memory problems. Then we progress more to the stage where people are forgetful, they're repetitious, they have clear problems, impaired decisional abilities, but they can still do quite a few things. And then we get to the more severe stages of disease where anyone can sort of tell there's a problem. And finally, we get to the most severe stage of disease where people are only oriented to self, they need help with all their basic activities. The key thing is that what we're talking about today for amyloid immunotherapy really is this mildest stage of disease, where the disease is just beginning. Some folks call this the mild cognitive impairment stage, but some people who are beginning to be impaired don't even meet the objective criteria for mild cognitive impairment because of their test scores. So this is the stage we're most interested in. It's very mild changes that are consistent. Changes can be in memory and or in other domains. And our thinking is that this is best discovered by talking to an informant, somebody who knows the patient well, rather than relying exclusively on testing the patient. So disease-modifying treatments are here. Hopefully everybody knows that now and everybody's using them. These are approved for very mild AD or MCI, as well as for mild symptomatic AD. And these medicines we know are lecanemab and donanemab, approved in the US and now undergoing approval in many other countries. These are IV drugs. They're given to 12 to 18 months. They clearly reduce amyloid plaques, and they slow progression of the disease by modest amounts, depending on what study you look at, by 25 to 50% over 18 months. And they do have side effects, and you'll hear more about that in a little while. The reason it's hard to find the right patients, because again, diagnosis is a clinical diagnosis, and this often requires objective testing, requires an informant, and there's no single test that I know of, no cognitive test, no MMSE, no MoCA, that can 100% diagnose symptomatic AD. It is a clinical syndrome. And again, it's most challenging at the milder stages of disease. The good news is, many of you in the audience are dementia specialists, and we're really good at this. We can diagnose AD in a clinical center with high accuracy, and this can be confirmed by biomarkers, which is great. But general neurologists, and I'm a former program director, I can tell you that many general neurologists are not trained in this. Psychiatrists may have some training, but there's not a lot of expertise in the community, and this is going to be a challenge because we want to recognize these people early and refer them in for treatment. What about biomarkers? So you'll hear a lot about that later in the session. This is a slide from my colleague, Dr. Schindler, and she's speaking in a session tomorrow more about this, so I'll put in a plug for that. But there's a number of biomarkers we can use. We can use amyloid PET, we can use CSF, we can use blood tests. They all have different pluses and minuses, but they all, if you choose the right biomarker, can be highly accurate for diagnosing AD pathology in the brain. But they're only indicated for symptomatic Alzheimer's disease, and we sometimes see in our practice people referred in who are worried about Alzheimer's disease. They have a family history, they get a biomarker, and then at this point we can't treat them because they're not symptomatic. That certainly may change in a few years. So I'll shift gears a little bit and tell you about how we have initiated amyloid immunotherapy at Washington University. We are just an overview of dementia specialty practice. We're associated with an Alzheimer's disease research center, with a medical school, with a regional hospital system. So we are in a very research-rich environment. We started discussions about amyloid immunotherapy back in 2021 when aducanumab was pending approval. These discussions continued to when lecanemab got full FDA approval in July of 23, and we treated our first patient in August of 2023. We treated our first patient with donanemab in December of 2024. At this point in our system, the prescription of these treatments is limited only to our specialty physicians, and this is great for having accurate diagnosis, but not great for access. So this is how it works. Patients are seen in our faculty clinic by one of our specialty physicians. We then refer them to an amyloid therapy clinic. They have 1 or 2 visits. We confirm eligibility. We do a lot of shared decision-making with the patients, and then we start therapy. There's a lot of behind-the-scenes work, confirming coverage, arranging for them to go to an infusion center. We had, for the first time ever, to have an on-call system because we want to know when our patients on immunotherapy have a problem. We have urgent visits as needed, and folks come in every 6 months while on therapy. We've changed this recently to increase referrals because that first box being seen in our faculty clinic involves usually a 4 to 6 month wait. And again, like in stroke, time is brain here for amyloid immunotherapy. So we're now having direct referrals from some of our colleagues who are also very good at diagnosing dementia, and we'll continue to pilot this. We use very typical inclusion-exclusion criteria, as you've seen in the appropriate use paper. Must have a diagnosis, a clinical diagnosis of very mild AD or MCI. We have to think AD is the biggest cause of cognitive change, so they can have comorbid conditions, unlike in some clinical trials, but we want AD to be the driving diagnosis. We look at it for an MMSE greater than or equal to 22, but there are exceptions for folks with aphasia. We have to have some sort of positive biomarker. We do use blood, highly accurate blood test. If it shows high probability, we take that as a positive biomarker. We do an MRI, and you'll hear a lot more about MRI findings in a few minutes. And we do treat ApoE4 homozygotes as well as those on oral anticoagulants, which is a little different than some centers. This is all in the context of shared decision-making with patients. So our advanced practice providers who staff this clinic sit down with the patients and their families and go over the expected benefit, the side effects. For more complex cases or those that we're not sure about, we do have a consensus conference where we talk about them. But in many cases, the individual clinician can make this decision in a typical patient. This is just a little about our therapy clinic. I've got to give kudos to our advanced practice providers. We have a PA and an NP who are both highly experienced in dementia care, and I think it is really important to use advanced practice providers because there are really not enough dementia experts on the planet to take care of all the folks with this disease. So they've been terrific at manning this clinic with backup from our physicians. We have a therapy coordinator, a nurse, and then an outstanding clinic nurse manager. And we recently started a referral pathway in Epic that helps those referring in to order the right scans. So this is what we've done over the last couple of years. We started patients on immunotherapy again in June of 2023, and again started off slow. Took off pretty quickly because we had a large backlog of folks who were interested in therapy. And that orange line shows you folks who are on lecanemab. Then in 2024, we began treating people with donanemab. That's the red line lower down, and the total line you may not be able to see, but it's, again, going up at this point. So we are continuing to treat more folks with about 20 to 30 folks started per month. This is great. It's really been terrific. Our staff is very busy, but we've treated a total of about 400 patients on these amyloid immunotherapies. You can see the numbers there for lecanemab and donanemab. But that's the tip of the iceberg in our metropolitan area. That's probably a tenth or less of the people who might need therapy. And there are a few other folks prescribing it, but not many. So the need is great, but the capacity is not as great as we would like. The lessons we learned in this first year and a half to 2 years is that it is really complicated to roll out this therapy. We participated in the clinical trials. We had some experience with these drugs, but getting them into the clinic is challenging. And we, again, had to hire a coordinator. I showed our spreadsheet at the bottom. It's on version 12,616, where we follow our patients on lecanemab, and we have a similar one for donanemab. So it's challenging to track these patients, to make sure you get the MRI scans, get them read, get everything done at the beginning. Not all neuroradiologists or imaging facilities are created equal, so it's great to have terrific partners, and I'm blessed with Dr. Benziger at my center, so she's been instrumental in making sure we get the right scans, we get them read appropriately, and our radiology colleagues were very involved in the early discussions to make sure we had capacity and the ability to do this. Experienced clinicians are great, and again, APPs can be very helpful. And then availability of biomarkers. In many countries, probably where you all practice, PET scans may not be available, so being able to do CSF studies, the availability of blood tests is very important. So why is early diagnosis so important? And this is just the data from donanemab, but there's similar data for lecanemab. The slowing of the disease progression seems to be greater at milder stages of disease. So that's why we really want to diagnose early. We can make the most impact on people's cognitive health going forward. And I think more of this data will be coming out showing that starting earlier gives us more impact, perhaps even in the pre-symptomatic stage, but we'll have to wait a few years for that. Side effects of these drugs, as you all know, and you'll hear more about ARIA from Dr. Cogswell, ARIA-E, ARIA-H. It's important to note ARIA-H can occur in AD without immunotherapy, so really important to understand that. And ARIA is usually asymptomatic, so it sounds really bad, but it is usually asymptomatic, more likely with ApoE4 alleles. These are the numbers from the published data on these studies, the incidence of symptomatic ARIA, which is really what we're worried about, symptomatic ARIA. And again, it varies with E4. It seems to be reasonably similar between the two drugs using the modified titration of donanemab. So that's terrific. This is the lessons from our first year. This is a paper published by Madeline Paczynski. Our PA is the first author, but citing our first experience with lecanemab. And important things to point out circled in the red here are that number one, it was not a particularly diverse group. This is a challenge for many centers, including ours. And secondly, most of the folks we treated were in that very mild stage, that CDR 0.5 stage, MCI, or even perhaps milder than MCI. So about 80% of our folks were CDR 0.5. We had about a 21% rate of ARIA overall, that's symptomatic and asymptomatic. But the important thing is we had a reasonably low rate, pretty close to the clinical trials. Again, this is a small number of about 6% with symptoms. Most of those were mild. I'll show you more in a minute. And all of them recovered from their symptoms. This is a bubble plot showing you a little more about the ARIA. On the panel to the left are the people with asymptomatic ARIA, and some of them have isolated ARIA-H, which is on the y-axis. Some of them had ARIA-E, which is on the x-axis. And as you can see, they're mostly mild. The symptomatic cases are the graph shown on the right, and none of them had isolated ARIA-H. All the symptomatic cases had either mild, moderate, or severe ARIA-E, a couple also with ARIA-H. And the key thing that we noted, and again, these are small numbers, so we don't know if this will hold out over long term, but for the folks that had symptomatic ARIA, the vast majority were CDR1. And as I told you, mild AD, CDR1, more impaired. And only 3 were in that very mild AD population. So the risk for symptomatic ARIA was much higher for those in the mild AD population. Those were not very mild, but were mild, and we'll be interested to see if this holds up. This means, again, it's really important to diagnose early. So there are big challenges in finding the right patients. Again, we can only see a small fraction of the patients at specialty centers, so we need to find ways to identify people early, refer them in. We're going to hear more about digital biomarkers from Dr. Solomon, so maybe we'll have some help there. We need to identify people when symptoms are very mild, again, when it's hardest to detect. So we need to think about our entire system, empowering primary care providers and others to recognize those with mild symptoms and refer them in. And our experience in the clinic, this is highly variable. Some PCPs are great at this, and some are not great, and our patients come in and say, yeah, I had to fight with my primary care provider to get referred in. So we really need a lot of education for that. We do need experienced clinicians to take care of these folks and manage these medications. And we need dementia specialists, the really super specialists at dementia centers, to be available when needed for the more challenging cases. So the bottom line, and I'm going to end like a minute early here, I'll have to talk slower. The bottom line is that, you know, I'm a gray-headed person, so I've been doing this for a while. So in the last 20 years, we've done a lot of trials that didn't work. So it's very gratifying that we now have 2 disease-modifying therapies after doing 300-plus trials in the U.S. that did not show efficacy. The biomarker changes, and you'll hear more about biomarkers in a minute as well, mean that we can detect the AD pathology very accurately even before symptoms start. So amyloid immunotherapy is here. We would order that it's safe and effective. We certainly need more efficacy data in the real world, but I think that will be coming. And it can allow people, and I didn't show this data, but certainly to have perhaps 8, 10, 12, 14 months more of independent living, so it does have efficacy. We'll find out about prevention therapies in the next 4 years, so those studies are ongoing for folks before they have symptoms. And we're going to hopefully continue to develop new treatments. And as we heard this morning at the plenary, this is critically important that we have support to do this. So the NIH has been very supportive over the years in the U.S. We hope they will continue to do so. Pharma has been very supportive as well. And you know, as a clinical trialist, I actually like the FDA because they do a great job of helping to bring new drugs to market. So I think all those institutions are helpful. And I think my last slide, none of this would be possible, again, as we heard this morning, without research participants. So kudos off to them. They have helped us get to this point. And this is just a picture of some of my colleagues at the Knight ADRC. This is an old picture, so there's even more now. But that's a great place to work, and I certainly recommend it. Other resources in case you need them. Thanks.
Thank you so much, Joy. All right, our next speaker is going to be Patrice Cogswell from the Mayo Clinic, who's going to be discussing with us the imaging recommendations and practice considerations for ARIA monitoring.
But I'll need a different set of slides.
Uh-oh. The incorrect slides are displayed. We'll pause your timer. So maybe while we're waiting for the slides, Patrice, you could just give a few comments about how the practice recommendations came about in that project.
Yes, so as the slides are up, and I'm going to be
talking. Keep going.
So I'm going to be talking about imaging recommendations and practice considerations for ARIA monitoring. And that's a good introduction, Tammy, that what I'll be talking about in part is the output of our ASNR, or the American Society of Neuroradiology Alzheimer's Dementia and ARIA study group. And we have a couple publications that will be cited during the talk that talk about imaging workflows for the detection and monitoring of ARIA. And so I'd like to thank all of the neuroradiology colleagues that are part of that group for their insights along the way, as well as colleagues within our Mayo Alzheimer's Disease Treatment Clinic and their inputs into effective workflows for imaging of ARIA. These are my disclosures. I'm going to briefly provide a background on ARIA, which I know many of you are familiar with, describe its imaging findings, and then focus on how imaging has been performed in clinical trials and then translated to clinical practice, and with that, some of the considerations going forward in the future. So amyloid-related imaging abnormalities, or ARIA, are edema, ARIA-E, and hemorrhage, ARIA-H, that occur in the setting of immunotherapies targeting beta amyloid. There's been lots of sessions at AAIC talking about ARIA mechanism, but as a brief overview, it is thought to result from loss of vascular integrity and leakage of fluid and blood products when amyloid is removed from the parenchyma as well as the vessel with these therapies. ARIA was first recognized in early clinical trials of bapineuzumab, and at that time, some recommendations provided for imaging to be performed in clinical trials. And since then, as we've heard, ARIA has continued to be an important side effect in subsequent therapies targeting beta amyloid. So now on to some of the details of ARIA. So first, ARIA-E can occur in the form of edema or a sulcal effusion and is identified on a T2 flare sequence. If there's leakage of fluid into the parenchyma, the result is vasogenic edema, as shown in the top image. So T2 hyperintense signal within the white matter may also involve the gray matter and is differentiated from acute ischemia by the absence of diffusion restriction. If there's leakage of fluid into the leptomeningeal space, the result is a sulcal effusion, as shown in the bottom image. ARIA has a predilection for the temporal and occipital lobes, and ARIA-E is a transient phenomenon, and I'll show an example of that in just a moment. So ARIA-H occurs in the form of microhemorrhages and superficial siderosis and is detected on heme-sensitive sequences of gradient echo or susceptibility-weighted imaging. ARIA-H often occurs along with ARIA-E, and when it does, the microhemorrhages are often clustered, as shown in the top image. When ARIA is identified, it must be given a radiographic severity score, and this is a score of mild, moderate, or severe for each ARIA-E, ARIA-H microhemorrhages, and ARIA-H superficial siderosis. And this radiographic ARIA severity score will be used along with any clinical symptoms to determine a patient's eligibility for continued drug dosing. Here's an example of ARIA-E. So first, this is the patient's baseline T2 flare. Post-dosing, there's a new right parietal sulcal effusion. This is one contiguous region of flare signal abnormality measuring less than 5 centimeters, so qualifies as mild ARIA-E. The patient was followed the next month, and we see that the right parietal sulcal effusion has improved, but a new right frontal sulcal effusion was identified. So now there's 2 separate regions of flare signal abnormality, less than 10 centimeters, so moderate ARIA-E. At this time, the patient's dosing was suspended, they were followed the next month, and the ARIA had resolved. So for accurate ARIA imaging, as we can see, ARIA can sometimes be subtle, and so to detect it, we need to image with high quality and also have consistent imaging across serial exams in a patient. In clinical trials, specific scanners are certified at each site for use, and a standardized imaging protocol is used. Typically, a T2 flare for ARIA-E detection, a gradient echo for ARIA-H detection, diffusion-weighted imaging to differentiate ARIA-E and acute ischemia, and a 3D T1, which provides structural imaging and volumetrics, and also allows for co-registration of exams over serial dates in a patient. Now that lecanemab and donanemab are available in some clinical practices, those imaging approaches have been translated into clinical practice. And when thinking about imaging in our clinical practice, it's been helpful to divide our needs for MRI imaging into 3 patient scenarios. The first is we'll call a baseline or enrollment MRI. That MRI serves to evaluate the patient's treatment eligibility and often coincides with their dementia diagnostic assessment. Second, brain MRIs are required during the first year of therapy to monitor for asymptomatic ARIA. And additionally, if a patient on amyloid targeting therapy develops new neurologic symptoms, a brain MRI is warranted to evaluate for ARIA. So based on those 3 patient scenarios, we can then consider imaging workflows for each of them. And I'll point out for us, the most important distinction here is workflows for what we would consider an AD therapy enrollment, or that baseline MRI, versus AD therapy monitoring. And it's important to distinguish those 2, as there's different key findings that the radiologist should be reporting. So for that baseline or enrollment exam, we need to report findings that would disqualify the patient from therapy. The number of microhemorrhages, infarcts, extent of white matter hyperintensities, versus on the monitoring exam to specifically report findings of ARIA. So in our practice, we have chosen the wording of AD therapy enrollment and AD therapy monitoring, and then we use that terminology consistently as the MRI brain order indication, the name of our imaging protocol, and also the name of our reporting template. And although we have these separate imaging workflows for these exam indications, as I said again, it's important that imaging is performed consistently across serial exams in a patient. Particularly, these 3 key sequences need to be performed similarly across all time points. And I'll discuss some of the details of those sequences. So first, the flare that is done for ARIA-E detection. In clinical trials, typically a 2D exam is done, so multiple slices through the brain. More recently, 3D or volumetric imaging has become available and may have some advantages. It's thought that either of these techniques could be used, but you should choose one and do it consistently. And here's an example of a patient who had their baseline MRI done with a 2D flare. Post-dosing, they had acquired both a 2D and 3D flare in the same imaging exam. And we see that in both cases, we see multiple new flare hyperintensities qualifying for moderate ARIA-E. I think in this example, it shows that although we can see the ARIA on both the 2D and 3D flare, the contrast properties are different between the 2, and comparison is best if we use the same technique over serial exams. Also, I think in this case, the ARIA-E edema stands out a bit more on the 2D sequence. So some considerations for a choice of 2D versus 3D. So 3D imaging has become very popular where available due to its higher spatial resolution, and for the FLAIR, less imaging artifacts. If all other imaging parameters are held equal, though, there could be longer acquisition time, as well as longer interpretation time as we have more slices to look through. And an area where we need more data going forward is the relative sensitivity of 2D versus 3D FLAIR for ARIA-E detection. And it may very well depend on exactly what the imaging finding is that determines which of those sequences performs better. So next, for ARIA-H detection. The gradient echo sequence, a 2D sequence, has typically been used in clinical trials, and that is the sequence on which the ARIA-H severity scoring has been based. However, susceptibility-weighted imaging, again, a more sensitive technique, is now more widely available in clinical practices. And in many clinical practices that have implemented lecanemab and donanemab, they are choosing to use SWI in their ARIA monitoring protocols, with the acknowledgement that this may lead to a more conservative treatment approach based upon data that we have from patients with cerebral amyloid angiopathy. So some of the considerations for GRE and SWI I'll discuss after we look at a couple examples. So this is a case where the patient had both a GRE and SWI done in the same imaging exam, as that is what we typically do at our institution, is acquire both of them. And in this case, the patient has 3 microhemorrhages, and they were seen very well on both sequences, which is often the case. In this case, however, the patient had clustered microhemorrhages, and we see more on the SWI versus the GRE. And here's an example of a patient with both ARIA-E and ARIA-H. And on the first post-dosing exam where the ARIA was identified, we see several microhemorrhages on the GRE. The next month, an SWI was performed rather than a GRE, so not an ideal situation, but that's what we had at the time. And we see more microhemorrhages, but we didn't know, did the patient develop more microhemorrhages, or were they just better seen due to differences in technique? So again, highlighting the need of a consistent imaging protocol across serial exams in a patient. So in our considerations of do we use a GRE, SWI, or both, we know again that SWI is more sensitive in general based upon the existing literature in other disease processes. And some of the questions that have come up are, should we use different exclusion criteria or a different ARIA-H severity scoring system if we image with an SWI versus GRE? And this is an area where, again, we need more data to know how differences in our acquisition technique affect the ARIA-H severity score and, importantly, patient management. And with this, we must also consider it's not just differences in the imaging sequence, but things that you could consult on your radiologist with is that there's also other factors, or what are the imaging parameters or the field strength that you're imaging that will also affect the sensitivity and must be considered. So we've highlighted here the importance of, again, using a standardized imaging protocol across serial exams in a patient, and that can be done by having dedicated imaging protocols for ARIA imaging. It's also important, ideally, that a patient be scanned on the same scanner over serial exams, and we do that in our institution by triaging patients to a specific set of scanners. I know that's not feasible in many practices, but it's ideal if possible. And looking forward, another consideration is that there's increasing MRI scan volumes that must be accommodated. And one way that we can do that is to use some of the more newly available accelerated imaging sequences. And this is an example of a 3D T1 on the left that was acquired with the standard acquisition approach and takes 6.5 minutes. On the right is an accelerated sequence, see similarly very high quality, but acquired in 2.5 minutes of image acquisition time. The use of these accelerated imaging sequences allow us to maintain the same image quality but in a shorter scan time. And those may be applied to decrease imaging time per patient, or may allow us to add advanced imaging sequences to some of our protocols. A final comment is on the use of AI-based techniques for ARIA detection. There are several techniques that have been or are in development, and 2 of the available techniques are shown here. And these detection techniques can help us identify ARIA, and may be particularly advantageous for less experienced readers. They may also be very useful in tracking imaging findings over time, such as microhemorrhage counts and things that may be time-consuming for the radiologist to enumerate. With these methods, like any other AI-based techniques, they may be sensitive to differences or changes in imaging protocols and scanners, and that is something we should be aware of. They're also typically tuned to be highly sensitive, meaning that we also need to be aware that there may be false positives that arise with these. In summary, ARIA are imaging abnormalities of edema and hemorrhage that occur in the setting of immunotherapies targeting beta amyloid. A consistent imaging approach is needed for accurate ARIA detection and severity scoring. In recent years, more advanced and sensitive imaging sequences have become available and may affect our sensitivity for ARIA scoring system and patient management, and that is an area where we need more data going forward. I anticipate ongoing advances in imaging that will help to promote safety through high quality, standardized, and efficient ARIA imaging. Thank you all for your attention.
The next speaker will be Dr. Iwatsubo from National Center of Neurology and Psychiatry, Tokyo, Japan.
Okay, good afternoon. So my topic may be the most difficult one, and one that we all wish could be answered. However, there's no relevant data or from evidence to support when to stop the amyloid based on biomarkers. So in my talk, I will compile existing data from previous trials or biomarker studies that may help us tackle this important question. This is my disclosure. So now I'm going to discuss the two anti-amyloid drugs currently used in clinical practice. There are lecanemab and donanemab. So first, for lecanemab, I have extracted the current dosing regimen recommendation from the drug label document. So lecanemab is administered every 2 weeks for the first 18 months. And the subsequent maintenance dosage can be either twice a month or once every 4 weeks in the United States, but with us in Japan, still twice a month. And there are some of the data from the open label extension study of lecanemab supported continuous dosing after 18 months rather than stopping treatment. And then a continuous treatment up to 36 months, as well as switching to lecanemab after 18 months of placebo dosing, produce clinical effects compared to the natural progression data from the ADNI study. And there was similar supporting data for the continuation of dosing from the biomarker study. So this is a blood plasma Aβ 40 to 40 ratio data. And then this showed greater dynamics in the open label extension stages and the PET amyloid quantitation changes. And then both in continued and then switched to drug in patients. So this finding may support the rationale for continuous dosing. And the question about when to stop lecanemab dosing was very actively discussed at the last IC meeting in 2024. And then ALS Forum summarized the major points as follows. Anti-amyloid therapy will no longer be effective when a patient reaches the advanced stage of moderate to severe dementia. And then of particular note is that tau-mediated and pathophysiology that will progress independently of beta from some advanced stage. And the simplest and the most widely supported answer was based on clinical findings. So that is, when patient progress to moderate dementia stages, dosing should stop, and there's no biomarker criteria with lecanemab yet. And the effect of anti-amyloid treatment can be assessed directly using a PET scan. Just so we can investigate whether the clinical effects of lecanemab can be predicted by a reduction in amyloid deposition at the individual level. However, this is a data. There was no correlation observed between amyloid PET reduction on the x-axis and the attenuation changes in CDR sum of X on the y-axis at the individual level and the clarity at the phase 3 study data. And only group level differences have been demonstrated. Then, can the plasma biomarkers predict the efficacy of the lecanemab treatment? So last year at the AAIC, data showing a statistically significant reduction in plasma p-tau217 or the CSF microtubule binding domain tau243 with lecanemab treatment at a group level was presented. However, no data relevant to stopping dosing is available yet. So regarding this issue, I would like to see the data on the relationship between clinical response and the plasma microtubule binding domain tau biomarker. And then MTBR is now named as a promising biomarker for the tau-mediated neurodegeneration. So next, donanemab. The case of donanemab may be apparently simpler because, as you know well, the treatment was designed to stop when the target disappeared, and the target amyloid deposits can be determined by PET examination. And as these data from the phase 2-3 clinical trial show that more than half of the patients treated with the donanemab drug and trials reached the amyloid negative level within 12 months, as shown in the leftmost graph. And even after stopping treatment, the effect continued to be maintained until 18 months. And this may support the cessation strategy. And then the rightmost panel showed the reaccumulation rate, which was at 2.8 centiloid per year, which is very, very similar to the natural course of the disease. And considering the higher amyloid removal capacity of the donanemab and the dosing setting, amyloid PET could be a reasonable biomarker to determine when to stop donanemab treatment. However, again, at the individual level, Trailblazer also trial found very little correlation between amyloid PET reduction on x-axis and the attenuation of changes in iDRESS and CDR, though the clinical effect at the individual level. However, when you use a decimal grouping review, it reveals that donanemab-induced amyloid reduction, as shown by PET, correlated with the clinical effects. And furthermore, lower post-baseline amyloid levels correlated with plasma p-tau biomarkers. As a last ADPD meeting which was held in Vienna this spring, Eli Lilly researchers asked whether a combination of early changes in plasma biomarkers could predict early amyloid clearance. And then Trailblazer 2 phase 3 trial data shows a positive correlation between early amyloid changes and early plasma biomarker changes. However, as this ROC curve shows, that plasma biomarker changes were found to have a very limited ability to predict the presence of amyloid clearance at that time. So what's then is the ability of tau PET levels that may predict the slowing effect of the clinical decline. So Dr. Mark Minton of Eli Lilly presented very interesting modeling data from an analysis using tau PET burden. And then the data suggests that people with the lowest baseline tau will best maintain cognitive function after treatment, which is shown on the leftmost side. And conversely, those with the highest tau on the right side will show the least slowing. So this is a summary. So whether anti-amyloid treatments are completed will be decided by whether the drug has been shown to have already had sufficient effects, such as removal of amyloid. Or alternatively, the drug has already lost enough efficacy, such as in a condition progression to advanced stages. Biomarkers that predict residual and future disease-modifying effects, or the lack of further efficacy would be useful in determining when to stop anti-amyloid treatment. However, currently amyloid biomarkers, including an amyloid PET scan or the p-tau217 or 181, are not sensitive enough to predict how individual patients will respond to anti-amyloid treatment in the future. Tau PET, which has been shown to predict the clinical decline, or the plasma T2 tau2 biomarker like MTBR tau243, could serve as decision markers if they could estimate the degree of neurodegeneration and the future possibility of efficacy. For now, it's per protocol. This is a conclusion. Clinical evaluation about whether patients remain in the early symptomatic AD stage remains critical for deciding when to stop treatment with lecanemab. And amyloid removal as assessed by PET or fluid biomarkers remain critical for deciding when to stop treatment with the donanemab antibody. So the results of the extension study for lecanemab and donanemab, which will be presented at this meeting, especially in reference to clinical biomarker outcomes, and will be crucial for the future use of biomarkers to determine when to stop anti-amyloid treatment. That's all. Thank you very much.
Thank you so much. I'm anticipating a lively discussion to come, because when to stop therapy is definitely a really important topic a lot of people are facing right now. So our final speaker in this session is Dr. Solomon, who's going to be presenting here from the University of Eastern Finland on digital biomarkers for monitoring disease progression.
Thank you. So now moving to the more exploratory part of the session. This is where we are now. So I'm going to talk about some key steps towards clinical use of digital biomarkers, and with some examples from digital tools that are currently implementation ready, digital cognitive assessment and clinical decision support systems. But first of all, what are digital biomarkers? A recent PubMed search with these exact words retrieved about 500 publications since 2014, and what is most striking in the scientific literature is how heterogeneous the concept is. Different studies use different definitions, and there are especially differences between the medical and technical literature. For Alzheimer's disease specifically, these are some of the most studied digital tools during the past 20 years or so. There's a very broad range of them that could potentially produce digital biomarkers. How about the regulatory perspective? We already have a well-established definition of what is a biomarker in general, and the regulatory definitions of digital biomarkers, which are quite recent, by the way, they build onto this established definition. For example, FDA added a specification that it's a characteristic or set of characteristics collected from digital technologies. And that's important because a single digital biomarker could be derived from multiple digital technologies simultaneously. And the EMA also added specification that for digital biomarkers, the clinical meaning can be established by a reliable relation to an existing validated endpoint. And that's a very important distinction because a digital biomarker is not the same thing as a clinical outcome assessment. If we take a standard cognitive test, for example, and we make a digital version of it and it gives us the same score we are used to, that is not a digital biomarker. But if this is done on a device, tablet, smartphone, and the device records, let's say, movement, speed, spatial features, and other features of how we interact with the device, then that can become a digital biomarker. But the scientific literature can and often does conflate all of these concepts. The regulatory landscape, for example, for medical devices and artificial intelligence, is also complex and changing, and that is also going to affect what is considered to be or not be a digital biomarker. For digital cognitive biomarkers specifically, I think they mark a fundamental conceptual shift from standard cognitive tests. If we look at the usual summary of disease progression, first there is brain pathology, and then there is cognitive impairment. Standard cognitive tests are designed specifically to measure manifest impairment, and that is why they have limited sensitivity in early disease stages. But newer cognitive tests are designed for a very different purpose. They're designed to use some sensor technology to measure some aspects of cognition via interaction with the device. They are not bound to manifest impairment. They're not limited to that. And they may actually detect subtle changes reflecting some aspects of disease pathology. For a standard test, because pathology comes first, we usually think of a biological marker. We need a biological marker to predict who is going to have cognitive decline. But with digital cognitive biomarkers, we can do it the other way around. We could use them to try to predict pathology. And that is one example from ADNI with the prediction of tau accumulation. In early disease stages, the initial changes may not even look like decline. They may look like something completely different. For example, lack of practice effects or expected improvement when we do repeated testing. Now, practice effects is something we don't want in a standard test. But something that's really bad for a standard cognitive test can actually become a very useful digital cognitive biomarker. And that's another example from a remote digital multi-day learning paradigm. So it's short repeated testing on multiple days, and it could potentially be used to distinguish between different pathology profiles. Where are we with the validation of digital biomarkers in general? Still early stages. This is a recent review, and you can see what percentage of the identified studies actually report diagnostic or prognostic outcomes. Several digital cognitive assessment tools are already approved by regulatory agencies, and it seems that both on-site supervised and remote unsupervised DCAs could be useful. But there are still gaps in assessing some of the crucial psychometric properties of these tools. And you can see here where the gaps are in a recent review showing what percentage of the identified tools actually have evaluated and reported data on key psychometric properties. Devices can record a lot of data from a lot of different modalities, but is high dimensional data always better? It may improve accuracy, but it can also create trouble with assessing the quality of a digital tool, and also to do what is a relevant head-to-head comparison between different tools and also between different digital biomarkers. What should be a suitable gold standard for validation? For later disease stages when there is impairment, it does make sense to compare to standard cognitive tests. But in early disease stages, there isn't much impairment, biological markers may be more suitable for validation. And the context and the purpose matter. For digital tools, it has to be very clear what is the intended use and what kind of setting it's supposed to be used in. And the same for the digital biomarkers validations. It is exactly the same as for any kind of biomarker. We need to know very clearly, is it diagnostic, is it prognostic, is it something else? Now, the posters have been removed already, but this is an example of an ongoing project where we are trying to address some of these gaps. It's a project funded under the EU Innovative Health Initiatives Public-Private Partnership Framework. And we are testing 5 different digital cognitive assessment tools in several clinical sites in several countries, also different populations and types of settings. And because the needs and also the preferences of different clinical settings can vary quite a lot, we decided not to force everyone to do the same thing in the same way everywhere, but we're using a more customized mix and match type of approach. The sites get to choose which tool or tools they are going to test. And this is being done in an integrated framework for 2 related sets of objectives: the classical validation of the digital cognitive assessment, but also blood biomarkers, and the evaluation of their implementation, because we need both of these analyses. Clinical decision support systems are particularly interesting because they can integrate multiple types of biomarkers, including digital biomarkers. A very rough definition would be that they are computer programs designed to assist clinicians by analyzing patient data and providing some kind of actionable output. And the analyzing data part is very important because they're not just visualizing data, they are analyzing and processing that data. They're not yet widely used for dementia diseases. Most of the available tools are focused on AI in radiology. We have one of those in our memory clinic focused on brain MRI. But a well-performing CDSS could, for example, help with reducing delays in settings where the availability of specialist healthcare services is more limited. And this is another example of an ongoing project under the same Innovative Health Initiatives Public-Private Partnership Framework, where we're working on developing this type of digital platform, or CDSS, with AI technology, aiming to assist clinicians with, for example, interpretation of complex data from multiple diagnostic modalities. There's an MRI module, there's a PET module, there's a digital cognitive assessment module. It is EHR integrable, so it can use other patient data as well. Prognosis for progression, relevant for patient management, assessing eligibility for disease-modifying treatments, and there's no AI involved in the last point, but I think it's very important, summarizing the complex information in a written format that works for patients, because they also have difficulty taking in this large amount of information that comes during assessments. Last but not least, there are still some key barriers to implementation that need to be addressed. Both healthcare professionals and patients overall do see value in digital tools. I don't think that's where the main problem is, but there are still a lot of ethical, legal, healthcare system and societal barriers to implementation. And I would like to end with this recent publication with a very interesting title. There are a lot of details discussed there, but I chose 3 key points to end this talk with. The digitized memory clinic is going to be a hybrid entity. It can never be fully digital or fully virtual. We still need the physical side of things. And these tools are not designed to replace, they're not meant to replace healthcare professionals. But we have to expect that the digital workflows are going to transform the current infrastructure and the care pathways. We can't just see them as an add-on to what we currently have, simply because there is little to no room left to add anything to the already very, very pressed daily work of a healthcare practitioner. Thank you.
All right, so many thanks to all of our speakers, and we're ready to have a panel discussion. You can walk up to the microphones and we'll call out the numbers. Please introduce yourself and tell us your institution. And we're also taking some questions from online. The first question online actually is related to the choice of amyloid biomarker at the time of therapy initiation. Lumbar puncture versus amyloid PET versus plasma biomarkers. And the question is whether or not, what is the experience with acceptance of the plasma biomarkers for enrollment in therapy?
Okay, I guess I'll start with that one. It's a great question, and I would certainly refer people to the paper I cited from Dr. Schindler about the different advantages. It does vary. I mean, acceptance can mean to many different groups, but the big one many of us are concerned about, particularly in the U.S. with our healthcare system, is acceptance for reimbursement. And there have been some issues with that. So some insurers do not accept that, so we have dealt with that. I think in general, hopefully as time goes on, and certainly with the FDA approval, that will become less of an issue. But so it really comes down to what's available where you are and what your patients accept. It also differential diagnosis is important. If AD is the only thing you're thinking about, then certainly a PET scan or blood test can be helpful. If there are many things in the differential, often CSF is more helpful. So it becomes an individual patient decision, and it's also important. And this is where we need more education for primary care providers and others, that if you're going to use a blood test, again, not all blood tests are created equal. So some of them are highly accurate and some are not. And it's important to use the correct blood test.
Okay, thank you. Anyone else on the panel comment on that? No? Okay. It looks like microphone number 5.
Hello, thank you. Oh, a little bit louder than I thought. My name is Jude Harrison. I'm an old age psychiatrist and academic from the UK. Fascinating session, thank you very much. My question was for the last speaker. I have some interest in medical device regulation in this space, and a lot of the technologies that you're describing would fall under that classification. I have some concern that the medical device regulation may delay the implementation of some of these digital tools, certainly in the UK. What's your view on that?
Yeah, that is true. They do fall under the medical device regulations, and they will also probably end up falling under different classes of medical devices, which have different levels of paperwork, etc. So that is true that the regulations are there, but I think that's a good thing, because there is a lot coming out now, a lot of various tools. It's a little bit of the Wild West out there. So I think it's a good thing to have some kind of order into that. And also the regulatory agencies, at least, I don't know about the UK, but in Finland they are cooperative, and everyone is aware that this is a very, very new field, and there is a lot that is constantly changing. So,
Thank you.
We're going to go to microphone 5 again. He was just in line already. Go ahead.
Okay, yep, thank you. I'm Rajit Shrestha from University Hospitals in Cleveland. My question is about ARIA monitoring for people who have a break in their treatment because of ARIA. So once their ARIA-E or ARIA-H stabilizes, especially if it's a gap of at least a few months, do we go back to the initial MRI schedule where we consider them as starting over, or do we? Is there any evidence to kind of tell us that people are still going to be at a high risk in the first 6 months after restarting, or whether the risk is lower and we should not do as many MRIs?
So that could be Patrice or Joy.
I'll let Patrice answer from the radiology perspective, but that's a great question. And the short answer for me is we don't know yet. And, we certainly are being quite conservative. And if a person is stopped for more than more than 2 months, we would probably go back to the original MRI schedule. And I think early on, we're going to do a lot more MRIs. As we get more data, maybe we'll learn that we don't have to, but right now we're being pretty conservative about it.
I agree, right, that I think they're sort of the making it up as they go along, but we're taking or the neurologists are taking a conservative approach. And so I think like if the MRI came up, they would probably still have maybe from the start of treatment, still like be counting those weeks for it'll come across as whatever, a week 27 MRI, but they may have added like, oh, we put the patient back on therapy, so we're going to do additional brain MRIs. But like you're saying, to be cautious if they were off for a few months or something.
Thank you.
So related to that, one thing that has come up for us recently is at WashU, our approach is it's like a hub and a spoke. So they get their 3T baseline MRI, but then they go out in the whole network and they're getting 1.5T follow-ups along the way. When we started the therapy, we didn't have amyloid PET reimbursement, but now we're getting amyloid PET scans to think about therapy changes or discontinuations. And we're realizing we need to repeat that nice 3T baseline MRI when they come in at that 12 or 18-month mark, because it helps us to understand the changes on the amyloid PET if we can see the changes on the brain MRI, and also reestablish that good high-resolution baseline after they've been out in our community scanners for a while, with the fear that if they had a late episode of ARIA, this would at least give us another time point.
And we're doing the same thing when the patient comes back they get an amyloid PET at baseline. All of our monitoring MRIs are done at 3T, but in some cases it might be a slightly abbreviated protocol from the full dementia assessment. And when they come in at that 12 to 18 month mark, again, we're doing the full dementia assessment MRI, and we just have a way of coding that in how it's ordered.
Okay, microphone number 1.
Hi, thank you for the presentation. Dr. Hidalgo from Neuromedical Clinic in Central Louisiana, United States. The question is about the combination of the biomarkers. Sometimes I went to the case that, you PET scan, and it's not clear that maybe look like could be positive. The numbers, the image is not very clear to me, so wondering if we combined CSF or blood. And done it with CSF in a couple of patients, but if you have any experience to combine, now the blood is more available, the tendency to, if one test is not very positive and clinically you believe that the patient could be early stage, maybe combines some biomarkers?
Yeah, I'm sorry, there's a bit of an echo, so I hope I understood the question. So you're asking about combining biomarkers?
Yes.
Yeah, I think that can be important, especially if one is equivocal. So as you were mentioning, if you have a very strong clinical suspicion and maybe you get a blood biomarker and it's the equivocal range, we would generally confirm that with the CSF or PET. If you get an equivocal PET, that's a little dicier because that's what the drug studies were based on, is having a positive amyloid PET. So, we often get cynoloid values if at all possible, but if a visual read is negative, you might look at the cynoloid value, but that would give me some trepidation about starting that patient on an amyloid immunotherapy, and I would think about potentially other causes for their cognitive change.
Thank you.
We have an online question for Dr. Iwatsubo. And it's related to the finding that about the relationship of the clinical outcomes and the changes on the amyloid biomarkers. And the question is, how does that inform your thoughts about mechanism and benefit of the treatment?
Yeah, that's a very, very big question. And so amyloid may be the cause of a neurodegeneration, but it's a multi-step process. And then amyloid causes a neurodegeneration, and it causes the failure of neurocircuit function. So there is a gap, between each steps. So that may be the one of the reasons why we see some discrepancy between the amyloid removal effect and the clinical outcome. So as I try to discuss, we may need some biomarker to predict the fate of the neurocircuit. And then that may be the tau-mediated biomarker. But we definitely need some biomarker evaluating the residual function of neuronal circuits. So that is a very complex problem, but we may have to appreciate the gap between amyloid and function. Yeah.
Okay, I think we're back to number 5 first. Sorry, I'm trying to remember who is in line first.
Thank you. Steve Hughey from Christiana in Delaware. My question concerns patients who are receiving anti-amyloid therapy. Do you have anything within your process that takes into account whom you offer donanemab versus lecanemab to?
Yeah, we generally do that as a shared decision-making process with the patient and their family. Initially, before the modified titration data came out on donanemab, we were having ApoE4 homozygotes preferentially go to lecanemab, but based on the newer data, the side effects are pretty equivalent. So really, it's a discussion with the patients and families. The efficacy data, you can't compare the studies directly, but it's very similar, I think, within the margin of error. So what folks come down to is, do they want an infusion every 2 weeks or every 4 weeks? And the other big consideration for families is some folks feel very strongly about continuing therapy or not, and that's something we've talked about. But the idea of stopping therapy after 12 to 18 months is very attractive to some patients and very unattractive to others. So it really comes down to an individual preference. And unfortunately now we don't have a lot of data to really advise them. So we leave that to the patients and families to express their preference.
Okay, number 1.
Daksha Vyas, I'm a neurologist practicing in Northwest Indiana Community Hospital and focusing more on dementia. And I had this question, which probably might be very simple, but what is SWI versus GRE and D2 versus D3?
So different ways that we acquire the imaging data. And so 2D is two-dimensional and versus 3D is three-dimensional, meaning the way do we image the brain is two-dimensional as slices versus three-dimensional, you get the way you're acquiring it as, to think of it as acquiring a volume and basically, thinner, so essentially with a volumetric or 3D acquisition, we'd have about like 1 millimeter resolution in all 3 planes versus 4 to 5 millimeter thick slices with a 2D acquisition.
Okay, and SWI?
And so a GRE is a gradient echo-based sequence, which is a standard, again, 2D sequence for detection of blood products. And susceptibility weighted imaging uses additional information from the MRI scan to help help you detect those blood products better.
And I would just add, if you're thinking about prescribing these medications, it's really important to talk to the radiology group you're going to be working with, because just de novo, every radiologist has their own favorite way of doing it, and so you don't get consistency. So that was why we did the project with the American Society for Neuroradiology to come up with standards that could translate what had been done in clinical trials into something practical for clinical practice. So I'd encourage you to talk to the radiologist ahead of time to make sure that they load the protocols on the scanner and that you know how to communicate the order to them so they know to run the right study and also give you the right report. And you can refer them to the ASNR website, or also if you're participating in ALSNet, in that registry, or even if you're not participating, if you go to the ALSNet website, it has a really good webpage with all the imaging resources there, including links to the protocols and the report templates and all of those things. But it is important to do that ahead of time before you prescribe the medication, because otherwise it'll just be chaos when you get the images and the reports back.
Yeah, and I would add to that, when you get your baseline MRIs, this is something we struggled with early on. We would have patients come in from other facilities with a baseline MRI done elsewhere. Very often, Dr. Benziger was kind enough to read them, but it does create a lot of variability. And then when you get that first MRI done at our center that shows a microhemorrhage, you don't know if it's new or not. So it's very important to have a high-quality, consistent baseline MRI and then those follow-up MRIs.
Okay, microphone number 5.
Hi, I'm Melanie from Washington University in St. Louis. Hi, Dr. Benziger.
Go WashU.
My question is for the last speaker as far as digital biomarkers and the accessible digital platforms in the works. You had mentioned some ethical barriers in that area, and I was hoping you could speak on those.
Yes, there are issues with it's ethical and legal. I guess it's a combination. So, for example, there's the data protection aspects, and then if we want, there are also the accessibility of the tools. Who has access to what, and those are just some examples I can think of right now. But data protection in particular is a major issue with digital tools. They can be so complex that sometimes when you see a tool presented to you, you miss some of the features just because there are so many of them. And some of the features that you miss involve, for example, which data is being saved where and for how long, and for example.
Thank you.
Related to that is an online question, and it says, are there any concerns that insurance companies might develop their own AI or digital algorithm and use it to either prevent patients from becoming eligible or to impact life insurance or long-term care?
I mean, that is I think the main purpose of having some kind of regulation on AI, especially AI that is used in the medical field, because that's just one really bad example of how AI could be misused for this kind of purposes. And there are many such examples. And that's why the regulations need to be there. That there should be, for example, in the EU, there are some uses of AI that are completely forbidden, and others are heavily regulated or more or less heavily regulated. So it's very important to have that in place.
So we've got a minute. I'd like to ask a question. Dr. Snyder talked about risk-benefit discussions with patients. Dr. Cogswell about risk based on ARIA and the limit of microhemorrhages. Dr. Subo on analysis of the PET data, and Dr. Solomon on digital markers. And all of these are based on extrapolating from a database to what is normal and what is not normal. So what I wonder about, to what extent you worry about our database and all of these is based on more than 90%, usually, at least in North America, white people, very few non-white people in the database, very few with early onset, and yet we're asked to extrapolate. So I would like to go through and hear from each of you how much you're worried about your database for Dr. Solomon, it's the future database of digital markers, but how big an issue is this now and in the future, particularly here in Toronto, where we have about 220 different ethnic groups, and we're trying to extrapolate from databases made on a very narrow segment of the population. So start with Dr. Snyder.
Yeah, that's a great question, and you know, certainly a major shortcoming of many of our studies is the lack of diversity. I think that's why it's important in a clinical diagnosis and in looking at comparing people to age-matched norms or other people. That's one of the reasons we rely so heavily on having an informant to tell us what's changed about that person over time. And I get excited about digital biomarkers now. I think that could be one way to certainly address that. Although after the last discussion, I'm worried about Big Brother looking at my Wordle score and seeing when I start slipping. But yeah, I think it's going to be very important to keep that in mind and to really look at intra-individual change as opposed to comparing people to databases that may or may not reflect where they come from.
I agree with that, and I think in a broader scope of our Alzheimer's treatment conference discussions, that we bring up routinely of the information, what information do we have versus what are the unknowns, and there are like you brought up the example of an atypical presentation, and so the degree of their severity based upon cognitive testing or their biomarkers, and so there's part of this, we're staying within the regulations based upon the data we have, but then there's also the gray areas, and where are you comfortable to sort of go into those gray areas, and let's say treating someone with an atypical presentation but maybe a low cognitive score somewhere where they've been comfortable with sort of extending the treatment. But there's other cases, I think, especially when you think about ARIA risk, of that the patient populations have very low vascular risk factors, by design in the trials, and that is an area where people are looking to expand treatment, but it also, as we know, comes with a greater risk. So that's an area where we're maintaining, to stay cautious, but we need to sort of gradually get more data.
Yes, so we have been learning a lot that from the very large-scale database like ADNI, that was done in the North America, and now we are in Asian countries, and then we have we are feeling that there's some commonality in the global data, and also uniqueness in the Asian population, like the difference in the incidence of ARIA in the clinical scene, and those initial database on the natural cause have provided us with very, very important information. But now we are entering the era of anti-amyloid and disease-modifying therapies. So now we have sometimes a difficulty in getting the natural cause data that can be compared with the treatment data. So from now we have to keep on expanding those international and national database on every aspect of Alzheimer's.
Dr. Solomon?
Yeah, so population diversity in data sets is a massive issue, especially when we start talking about AI and tools or biomarkers that are based on AI. And I was reading recently a study, I think it was in one of the Nature journals. It was about an AI tool that is commonly used in the clinic in radiology for diagnosing lung conditions. And that tool had been developed, so lung research, they have massive, very diverse data sets from all possible countries and continents. So it looked like a great training data set, and it still had biases. So it consistently had poorer accuracy in diagnosis in specific groups, ethnic groups, or younger women, for example. So it still had such biases even after being trained on a very diverse set of data sets. So yeah, that is definitely going to be an issue.
All right, is that microphone 5 again?
I wanted to ask a question.
Please.
My name is Dr. Wakas. I am from University of Debrecen, Hungary. I wanted to ask that are there any blood tests or something like that can help us predict the chances of side effects in patients with anti-amyloid therapy? I think it's getting double voice or something.
Great question. I know that our clinic and many others around the country are collecting blood on our anti-amyloid patients. I don't know of any right now, but stay tuned.
Thank you.
All right, well, I think with this we can conclude our session and just let's have a round of applause again for these fantastic speakers and their perspectives.
And don't forget to sign up for CME credits at the door.